Hello, everyone. This presentation will cover vulnerable populations. This presentation is under our health disparity um, topic that we'll be covering this week. There's been noticeable changes in the U.S. demographics, and these are some of the trends in those demographics. Approximately 15%, there's been about, excuse me, there have been approximately 15% increase in the population that are at or below the poverty level. So we know that there's more people who are at or below the poverty levels. Those that trend has been increasing over time. We also know that approximately 25% of adults have a chronic health condition. Um, we know that poverty, a major social determinant, is concentrated in urban cities and rural communities. In the US, it is becoming more diverse, and in between 2015 and 2016 specifically, Asian Americans and mixed race groups are the fastest growing segment of that diverse populations. We also know that America is graying. We have approximately 8,000 baby boomers turning 65 every day. We also know that these older Americans that are graying and increasing in numbers over time suffer from chronic conditions such as hypertension, diabetes, cancer, heart disease. Racial minorities have lower life expectancies and higher rates of chronic disease and stress. Again, we know that racial minorities have lower life expectancies and higher rates of chronic disease and stress. And we also know that older adults, our aging populations, also suffer from major chronic conditions, hypertension, diabetes, cancer, and heart disease. And this is concerning because we know certain chronic diseases from our other PowerPoint that we discussed really are the leading cause of death in the United States, particularly cancer and diabetes. We also know that individuals that are at greater risk for poor health outcomes um, and and healthcare access, and this represents a major challenge for vulnerable populations. We also know that when you categorize by age, demographics, healthcare, accessibility, and race, vulnerable populations tend to appear um, in terms of people who are older adults, in terms of age. We know that demographics and race includes urban neighborhoods and people of color, that being African Americans and Latinx population. And we know that there's a concern when we're talking about healthcare accessibility specifically and what we mean by that. And so, healthcare accessibility can mean access to health settings that are nearby. When we think about access to healthcare, we think broadly also about the availability of quality services. And we also know that finances play a role in accessibility for healthcare. That can mean insurances or people who are underinsured or have no insurance. And that can mean people who have insurance, but because of the way their insurance policies are written with high deductibles and copays, that it still deters patients and individuals from seeking the health care that they need. When we think about vulnerability in health, we are thinking about areas of vulnerability that includes physical health, mental health, as well as social factors. So a person can be vulnerable to poor health outcomes based on these areas. So when you think about people or individuals or populations of people being vulnerable from a health standpoint, think comprehensively about all the different ways that they can be vulnerable. Think about physical limitations, such as somebody who can't walk, a person who may not be able to see or hear. Also, think about mental health challenges such as depression, schizophrenia, Think about social factors, and those are social determinants of health: housing, employment, etc. 25% of adults in the US have at least one chronic health condition. Again, we know that 25% of the adults in the United States have at least one chronic health condition. We had an economic downturn between 2007 and 2008. And even though that was a considerable time ago, we know that the United States is still overcoming that economic downturn. Most recently, COVID-19 specifically has taken another hit and has provided another economic downturn for the United States to overcome. Even though we are far from we are far from the end of this public health pandemic, but we can still see now through closing of businesses, loss of jobs, the requirement for stimulus packages for the general public, as well as disaster loans that are being offered toward businesses, are all signs that the United States, at least at this point, is trying to avoid a serious economic downturn. But again, we can still see that there is starting to be signs of economic downturn just by paying attention to loss of jobs and closing of large businesses and smaller business. Public services and entitlement programs are at risk of losing federal funding. This is not specific to COVID-19, but whenever there's an economic downturn and the government is trying to be conservative with spending out of concern for the economic downturns and the cost that it will um, um, total for the government, the first areas that tend to be cut when expenses are being pulled back are public service programs and entitlement programs. And that means vulnerable populations are at risk oftentimes, because those are the groups and populations that are targeted for public service and entitlement programs. Healthcare reform efforts, such as, for example, the Affordable Care Act, continue to move forward. Historically, federal and state policies target populations who are most vulnerable. For example, people who are poor or impoverished, um, people who are uneducated, um, immigrants, and minorities specifically. And so these groups are most at risk when there are cuts to entitlement programs. There are health service options for vulnerable populations, and this slide lists the type of health services available for people who are considered, or groups that are considered vulnerable populations. Public hospitals, federally qualified health centers, community health centers, migrant health centers, healthcare for the homeless centers and programs, public housing primary care centers, and these are primary care centers that are housed right within public housing programs, rural health clinics, Indian health services, mental health, substance abuse, and HIV programs. There are also social service options that we think about when it comes to vulnerable populations, and these public health um, these social service options are supposed to improve overall public health. Think about the Supplemental Nutrition Assistance Program (SNAP), which provides additional support for people who need cash assistance or food stamps specifically. And I'm dating myself; they don't even call it food stamps anymore, but your card. Women, Infants, and Children, WIC, is another program which offers supplemental nutrition support for um, perinatal population, pregnant and postpartum women and children. Think of your National School Lunch Program, and it's how it supports low income um, families and children so that they have nutritional support during school. One of the things that you may have noticed is that during COVID-19, when the schools closed back in March, one priority was keeping some type of um, nutrition support program open. So even though schools closed, a lot of families were encouraged to continue to take advantage of the school lunch programs that were offered. They continued to make sure that public health need was met. And these lunch programs are important because we do have research that shows that there are some students that is their primary food source, the lunch, the breakfast and lunch programs that they actually receive from school, those who are at and below the poverty level. And we also know that in terms of supplemental nutrition assistance programs, these and women, infants, and children, these programs are important because they help support healthy nutrition. A lot of times, women, infants, and children, the WIC program, they're very specific on the types of uh, food support that they will allow a pregnant postpartum woman to purchase. And the goal of that is to make sure that the choices are healthy to support her at that stage of her life and children and the children as well. Temporary assistance to needy families, TANF, Medicare, Medicaid, and CHIP. We will talk more about that, which are payers. Medicaid is insurance for people who are at or below the poverty level. Medicare is and Medicaid is considered a vulnerable population under poverty, and Medicare is insurance and supplemental insurance for people who are 65 and older, another vulnerable population because they have high risk of chronic health disease, chronic health conditions, and CHIP, the Children's Health Insurance Program, which is affordable health insurance for working parents who are low income. We also have Supplemental Security Income, SSI, that offers supplemental insurance or payments to a special group of people, SSI. SSI, which is our Social Security Administration, is a larger program that covers supplemental insurance and or medical insurance, supplemental medical insurance for people who are disabled, low income, or have other needs that need to be met financially, either due to loss of a spouse and so forth. And there are other criteria to qualify for Social Security Administration programs. Unemployment insurance, you've been hearing a lot about that since COVID-19 and how the unemployment insurance applications have been increasing, and housing assistance. And one example is the McKinney-Vento Homeless Act. If you have time, please look that up. That is a very interesting program to help improve housing outcomes. Healthcare payers include government and federal, states, local government, private organizations, insurance companies, and philanthropic groups and hospitals. Again, when you think about payers of healthcare services, these are the areas or the main larger categories of payers. That's government and federal, which you see listed up here as Medicare, as an example. Supplemental security insurance is another example of government and federal payers. State and local governments are also payers. Think about Medicaid, which is a state, is federal funded and administered by the states. Some states also provide some financial support through Medicaid as well. And private organizations, insurance companies, and philanthropic groups, and hospitals. Some of the major insurance companies, examples, Cigna, CareFirst, for example, and Aetna, Health Partners, which is a Medicaid, but it's a administrator for health insurance. Cigna, CareFirst, are some examples of insurance companies that you may be familiar with. Um, Philanthropic groups or charity organizations, social service groups that provide support for medical bills. Um, and hospitals. Oftentimes, hospitals have programs to assist patients who cannot afford to meet their health care needs. When you think about healthcare payers, Medicare is one, and it covers patients who are 65 and older with a qualifying disability. More information can be found at this website on Medicare. Medicaid, low income individuals or families below the federal poverty level. So, again, Medicaid is a healthcare payer that individuals are eligible for if they meet certain income criteria, particularly low income and or below the federal poverty level. CHIP, the Children's Health Insurance Program, is for children up to age 19 with family incomes higher than the federal poverty level, and information on CHIP can be found here. And it's managed by the Center for Medicare and Medicaid Services, CMS. Limitations in our current healthcare systems, fragmentation of services, services by different providers who are not co-located. So when we think about vulnerable populations, one of the biggest challenges they face in our healthcare system is fragmentation of services. The reverse of fragmentation is care coordination or coordination of services. We know that if fragmentation of services result in adverse outcomes for patients and adverse experiences, we know that care coordination improves the quality of care and improves healthcare outcomes for individuals and patients. Silo care. This is where there's multiple providers who do not consult with each other. They're not collaborating with each other. So you may have a person who has um, heart disease, and their primary care doctor, who's responsible for most of their routine appointments, care, testing, and screening, working in their medical office. And you may have a cardiologist. They're one of the a specialist for that particular patient who is seeing and working with that patient specifically to address the concerns about uh, um, the heart condition. But yet they never collaborate with each other. They don't share information. And we do know that when healthcare providers work together through care coordination models, primary a medical home model, when we know that they do not um, consult with each other, round with each other, do all those necessary care coordination activities that improve outcomes, vulnerable populations suffer. And communication is big. We do know that there are some policies that are in place that make it very challenging for providers to communicate, even though they're put in place to protect patients, such as HIPAA. HIPAA is put in place to keep medical information, protected medical information private, but it also provides a barrier for healthcare providers to talk to one another because oftentimes informed consent is required in order to share personal and protected health information. And so that step sometimes in that administrative process of getting those consents signed and sent over, and is cumbersome. Volume versus value and quality. We know that's another limitation in our healthcare system. And that just means that the way that the healthcare system is set up, reimbursements and revenue is based on volume, the quantity of patients seen. So the more patients that are seen and the higher acuity or the more chronic their illness is, that the more the healthcare system makes in terms of revenue. Where a lot of models are now looking at value-based care and quality-based care, incentivizing healthcare providers and institutions for the quality of the care provided rather than the number of patients that they're seeing. Right now, the more patients a provider sees, the more money they make, whether or not that patient is getting better or improving health outcomes. Another limitation of the healthcare system is the disease model versus wellness. That is more, the disease model is more a reactive way of dealing with health issues. Think of secondary and tertiary intervention from our earlier PowerPoint slides in the beginning of the course versus wellness. Wellness will be your primary care intervention model that we use. And so oftentimes providers and healthcare systems are disease model focused, and that they only intervene and get involved in care when things are wrong, when the chronic condition is already diagnosed or diagnosable and has worsened over time. And that's a limitation. A lot of the healthcare reform now is believing that um, more money, more support, more focus should be on wellness and prevention programs, and that will decrease the overall cost of healthcare by keeping individuals, populations, and patients well, rather than spending more money after they get sick. Addressing limitation, as I stated, care coordination models are key with emphasis on primary care. Again, coordination of care, accountability for outcomes, and that's that value-based model system. We also know there are evidence-based care coordination models that are working and are serving to improve outcomes for certain patient population. The bridge model is one of them. Please review this care model that focuses on older adults and how this model incorporates elements of care coordination to improve outcomes for vulnerable populations. Patient engagement and team-based care, that helps address the issue above when we talk about the limitation on silo cared and fragmented services. And so what we do know is team-based care and patient engagement approaches help improve fragmented and siloed care, because the team-based care encourages collaboration and communication to improve quality of care. But we also know that patient engagement is also important because this invites the patient to the care team as a member of the care team. And so including the patient in the decision-making progress and empowering the patient for their care. Integrated system models are also important. And an example of integrated system models includes use of data, electronic health records, mobile applications, and telehealth services. You talked about this in your health technology papers, but these integrative systems models and technology specifically can improve overall health outcomes for populations and individual patients. You've talked about that in your healthcare technology papers, but of course not without limitations, as you all know and again discussed in your paper. Patient-centered medical homes. This is a CSWE patient medical home webinar. Please click on this on the original PowerPoint that's in the folder. These patient medical homes are primary care-based models, and it really addresses the issues of prevention and wellness models, meaning coordinated care and emphasis on quality primary health care, but it also incorporates uh, collaboration with other providers to improve care coordination as well. The Affordable Care Act. The Affordable Care Act is one of our most largest transformational changes to our healthcare system in a long time. There have been monumental changes in how healthcare is paid and how services are delivered through the Affordable Care Act. The Affordable Care Act focuses on value-based care. It also focuses on increased coordination in health and social services. So again, in this healthcare reform model, social services is identified as a key area to target to help address those social determinants of health. Also, integration of physical and mental health components under the Affordable Care Act. For instance, pre-existing health conditions are covered under the Affordable Care Act, with prior to that it was not. And there was a mental health component. You may want to review the Mental Health Parity Act, which makes sure that mental health gets the same priority by healthcare payers as a physical health condition. Prior to that, physical health conditions were prioritized and authorized for payments when oftentimes mental health coverage was lacking. And so through the Mental Health Parity Act, mental health conditions are prioritized as important, and insurances must provide coverage and authorize coverage for mental health just on the same level as they would a physical health condition. There's also been a focus on Medicaid patients, those who have chronic health conditions and poor. Again, two major areas of vulnerability for populations. So, what the Affordable Care Act has done is it's expanded Medicaid, uh, expand Medicaid eligibility for many people. For those states that accepted the expansion, there are some states, primarily through leadership, through political leadership, that being um, governors, um, that did not want to accept Medicaid expansion. And so each state had the right to accept Medicaid expansion or not. In some political views, entitlement programs and the expansion thereof is not aligned with some political views. And oftentimes that you will see that with the Republican Party. However, there are some Republican-led states that did not want to accept the expansion of Medicaid, and so they had the right to not do that. You can look up information about that online. And I think in the Blackboard, there may be some a map listed where you can see states that have expanded Medicaid and those who chose not to. Health homes, two or more chronic conditions. So to have a medical home, this was talked about, a patient medical home, they focus on those who are the most vulnerable. And one of those populations are populations that have at least two or more chronic conditions, chronic health conditions. So if you had two or more chronic health conditions, you qualify for a medical home or what they call a health home. And that focus would be on primary care, but also more higher level chronic needs as well. So keeping them as healthy as possible and make sure they're screened and they don't have other health issues, but focusing on two or more chronic issues specifically to make sure those conditions are managed and they do not worsen. Um, Also, Affordable Care Act included comprehensive care management, intensive care transitions, care coordination, individual and family support. All these fall under the enhanced support and healthcare benefits for Medicaid patients specifically. The Affordable Care Act focused on value-based care instead of fee-for-service models, which was the primary model before Affordable Care Act. So incentivizing and reimbursing providers based on the value and the outcomes of healthcare received by them by patients rather than the fee-for-service model, which, as I stated earlier, is a model that reimburses and incentivizes providers to make more money by the quantity of patients that they see. Um, Also, accountable care organizations were a focus in Affordable Care Act, and that is provider hospital groups who partner and collaborate to provide coordinated high quality care. And so higher or better reimbursement for value-based models, and accountable care organization would be a value-based model where providers are not working siloed, they're communicating, and there are groups that are connected with providers are connected with hospital groups who partner and collaborate to improve the overall quality of care patients receive. This accountable care organization, accountable care organizations provide services to at least 5,000 Medicare beneficiary in 3 years. If you remember, Medicare service populations that are 65 and older and or with a disability. And it focuses on those with most chronic and acute health and social needs, and targeted efficient care without service duplication, which is cost savings, which is meant to yield a higher cost savings and better quality care for individuals and patients. And again, I keep wanting to stress here that healthcare reform, and one of the key components that speaks specifically for social workers, is that this is the first time healthcare reform in a long time is focused on social needs as being a key to healthcare outcomes. However, there are some limitations to the Affordable Care Act. It's expected that up to 8 million people can't afford to participate in the exchanges, though there has been some modifications to the cost to participate in the exchanges. But when it was first rolled out, there was many people, again, 8 million, who couldn't afford to participate in the exchanges, particularly for the 26 states that rejected expansion. As I stated earlier, there were some states that rejected expansion. 11 million undocumented immigrants were excluded in the ACA, and that's a limitation. There are reduced payments for disproportionate share hospitals in areas with high immigrant population, and rejected Medicaid expansion is troubling because that um, decreases the amount of people who are that can be eligible for assistance and support. More investment needed in social service sector to address social determinants of health. So even though the Affordable Care Act is one of the first legislations related to healthcare in a long time that focused on social needs, a lot more investment is still needed in the social services sector to help address what we know to be social determinants of health, which is a key or large factor in healthcare disparities. Thank you very much for taking the time out to listen to this PowerPoint presentation related to vulnerable populations, and taking the time to learning a little bit more about healthcare payers and the Affordable Care Act. I strongly encourage you to watch the webinar and review some of the websites that are listed on this PowerPoint and in your Blackboard to learn more about vulnerable populations, healthcare disparity, health payers, and other value-based care models. Thank you.